Hello, I'm Jeff with Indiana Donor Network. I'm here today to talk to you about donation after circulatory death. I'm the manager of the in-house recovery and perfusion operations here at Indiana. I came here in December of 2020 after working 16 years in the OPO community. Let's kind of go over our objectives today. How did we get here? And what I mean by here is how we got to work with DCD and brain dead donors, understanding the two types of death and donation, understanding how death definitions frame our process, the DCD process versus brain dead, the referral evaluation, DCD donor process, and DCD OR needs and communication with hospital staff. A little bit of the background. Regulatory bodies that Indiana Donor Network works with to create all our policies and procedures are UNOS or OPTN, United Network of Organ Sharing, and Organ Procurement Transplant Network. They're kind of one and the same, and we'll go over that a little bit more here in a minute. And Centers for Medicare and Medicaid. CMS, AOPO, which is Association of Organ Procurement Organizations, CLIA, our internal policies, hospital policies, and Indiana code status is how Indiana creates all their policies and procedures and how we work with donor hospitals. So let's talk a little bit about the National Organ Transplant Act. Summary of events and the timeline to address the national critical organ donation shortage and improve the organ matching and placement process. Congress passed the National Organ Transplant Act in 1984. OPTN was established to maintain a national registry for organ matching. The act also called for the network to be operated by a private nonprofit organization under federal contract. UNOS was awarded the national contract for OPTN in 1986 and continues as the only organization ever to operate as OPTN. OPOs must be members to receive payment by Medicare, and funding by the OPTN is through the Health Resource and Services Administration, HRSA. The National Organ Transplant Act in 1984, Congress became aware of the fiscal impact and was determined to increase the number of transplants. For instance, it is more cost-effective to perform a kidney transplant than it is to perform dialysis for a kidney failure patient over time. In 1984, NOTA was put into law and outlined the framework to develop the National Organ Donation and Transplantation System. The independent OPO basically is an organization authorized by Centers for Medicare and Medicaid system to work together to procure organs for transplantation. Our responsibility is to simply obtain the organs for which have been donated by individuals after death and distribute those organs in an equitable manner to transplant centers. IDN is the sole nonprofit OPO or organ procurement organization in the state of Indiana. We are one of 57 national OPOs, and we provide donation services to over 155 hospitals in the state of Indiana. On a daily basis, we work with the donors and their families to honor their decision to be a hero. Not only do we facilitate donation, it is our responsibility to reach out to almost 7 million people in the state and give them the correct information on donation. Transplantation is not possible without the transplant centers and donor hospitals' cooperation. UDDA is the Uniform Determination of Death Act, national legislation from 1980 enacted by all 50 states. This is the uniform law that states how someone can be declared dead. In the determination of death, this is how death is determined in the DCD process. The patient's heart stops functioning and breathing has ceased. The death will be declared by a licensed medical professional and per their hospital policy. In brain dead donation, each hospital has a policy on how to declare their brain dead patients. Indiana Donor Network just assists in making sure that these policies are followed. Let's talk a little bit about what is DCD. DCD stands for Donation After Circulatory Death. DCD provides an opportunity for the recovery of organs for transplantation from donors after declaration of death from circulatory criteria. This provides patients and families an alternative means to organ donation when the patient does not meet brain dead criteria. This should be viewed as a component of end-of-life care. This is a family-driven process. Their families have already decided to withdraw care, and this just gives them an opportunity at end of life to be heroes to others. There are over 115,000 individuals on the waiting list for life-saving organs. There are not enough organs available from just brain-dead donors to fill the need. As you can see, only 0.05% of patients die from brain death. This is a huge gap from the number of brain-dead donors to number of organs that are available for people that are on the list waiting for a life-saving transplant. 115,000. Just think about the University of Michigan football stadium. That holds 107,601. We could fill that whole entire stadium with the number of people that are waiting for a life-saving transplant. There's not enough brain-dead donors that would be able to give that gift of life. So let's talk a little bit about the two types of donation. They're a little different. So if we look at the DCD, you have the withdrawal of life-sustaining therapies or withdrawal support. You have a period of time that the patient will desaturate with their oxygenation, agonal phase with their vital signs. During this whole time, you will have possible damage happening to the organs. Then you have circulatory arrest. We have a 5-minute window from the time that we have circulatory arrest with the patient being declared deceased to the time that we can start our surgical procedure. And then we try to cool down the organs as quickly as possible. Now, the brain dead process, which is much better and has less trauma on the organs, basically we go into the OR, we start the OR procedure, and then we identify the different vasculature, take a look at the organs, identify how the organs are functioning within the systems, and then we're able to do what's called a cross clamp. At that time, we turn off all ventilation for the patient and we arrest the heart, and then we have the recovery process take place. This is a much easier process on the organs than having the DCD process. However, we work with the DCD patients to provide extra organs for transplant. And we have found that over time, we've been able to have different modalities that will help with the process of DCD. So if you look at this diagram, the family decides to withdraw and the patient is not brain dead. Again, we always say that brain dead donation is better for the organs. It doesn't always happen. We talk with the family, we get authorization and disclosure from the legal next of kin. We do our donor workup with hospital still managing the donor. So we work with the hospital to get the labs that we need, any testing that we may need, like a CT, bronchoscopy for the lungs, and we also can get an echo for the heart or even a cath if needed. Then we get ready to set OR and we move to the OR for withdrawal of medical therapy. During that time, the hospital will have the physician or whoever is pronouncing per hospital policy, also the nurse that's taking care of the patient at bedside, an RT, and we will be in the OR for withdrawal of care. At the time of death, we wait 5 minutes from the time of death to the recovery process. Brain dead process, the patient is declared brain dead. The authorization or declaration with the family, the legal next of kin. We start our workup, we perform and we write the orders for any of the necessary modalities such as echo and bronchoscopy. Many of us, we can perform those functions in the hospital ourselves as well, or we could transfer to our organ recovery center here at Indiana Donor Network and perform those functions here. Then we get ready for our OR and we head into the OR and we do the recovery of the organs. It's much more controlled. So the referral and evaluation process. So these are the referral triggers that we ask the hospitals to give us a call so we can start to take a look at the donor or a possible donor. GCS of less than 5, regardless whether there's sedation or not. Poor prognosis, beginning and the end of life conversations with the family, and family mentions donation. If the family mentions donation, we should be in front of them talking to them. Then we start the referral process. We are able to follow the patient and see how they progress. Many of the patients will get better, which is great. The ones that do not get better and move towards the withdrawal of life support or reach brain death, then IDN should be involved. So again, hospital calls in the referral. It goes into our VitalLink, which is our donation call center. A referral runner will go to the hospital, look into the chart, find out a little bit about medical history, how the patient's doing, look at organ function, and then we'll talk to our clinical supervisor or AOC to determine whether the patient will be continued to be followed for donation possibilities. So the determination of eligibility, we take this seriously. We go through looking at everything. If they're medically eligible, we look at their past medical history, social history. We look at the admission course, any past surgeries that they may have had, organ function, acute versus chronic injury with the kidneys and other organs, the hemodynamics and urine output, whether they're on any inotropes or vasopressors, neurological function. We will ask to have a neurological exam done just to see where they're at, whether they're on sedation or not on sedation. We look at the radiological studies and diagnostic tests. All this together paints the picture for the patient, whether we pursue for organ donation or not. Even one life-saving organ is worth going through this process. DCD is a family-driven process. They have made the decision to withdraw life-sustaining therapies after speaking with the patient care team. So we do not get involved until it's that time. We don't talk to the families. We might be in the background determining whether the patient has eligibility or not, but we will not get involved with the family until there's been a discussion with the family about end-of-life care. When a family considers or makes a decision to withdraw medical therapy, Indiana Donor Network needs to be ready to talk to them and give them the correct information to see if they would like to pursue for their loved one to be a donor hero. An early call to IDN is always better than a late call. Most families do not decide to withdraw life-sustaining therapies without having multiple conversations about their loved one's care plan. There are rare occasions that this happens, but it is the exception, not the rule. It does take time for IDN staff to get on site and evaluate the option for donation. We ask that the care team treat for the option of donation while we gather all our needed information and make the decision to offer donation to the family. It is really a group effort to make this happen. So again, a little bit more about the determination of eligibility. Laboratory values, we look at diagnostic testing, imaging, neurological assessment, cardiovascular assessment, respiratory assessment, and through the medical history review. If there's a possible of even one life that can be saved through organ donation, we will pursue. So we use visual analytics to help us determine whether these organs can be transplanted or not. It's a program that was developed with transplant center data, and they input their data from all over the country to help us determine if this patient would actually be able to save even one life. So we import all the data from the patients, and then we run a report. This is kind of like the report that we get. This is off a DCD donor, age 60 to 70, so our older upper threshold of a DCD donor, and we look at the visual analytics. As you can see throughout the nation, there's organs being transplanted from this age DCD donor. And I chose age 60 to 70 because it's really pushing the limits. And if you look around the country, you'll see some of the areas that are a little bit more aggressive with organ transplant. So we also look at the KDRI or KDPI. Basically, it's a donor risk assessment on how we think these organs will do, the kidneys. We have the ability to provide additional data to transplant surgeons at the time of recovery of the organs. We can place the kidneys on pumps that provide flow and resistance. We can take biopsies of the kidneys and give the transplanting surgeons the information prior to them accepting the organs. We also have the ability to place lungs on ex vivo machine, and we can use ECS or extracorporeal support for DCD donors to allow the donation of heart and lungs. These are all newer technology in the last 10 years that have really expanded the opportunity for DCD donors to save a life. So this is our DCD evaluation tool that we do on almost every donor as the decision to withdraw support is being made. We take a look at all the information in here to help us determine whether we are going to pursue for organ donation or not. We take it very seriously, and many times we'll do this DCD evaluation if there's going to be a family meeting to talk about end-of-life care. And if they don't decide to withdraw support, then we will again perform this DCD evaluation tool just prior to when they do decide to withdraw care. It gives us the most up-to-date information to be able to determine if this patient will pass in the 90 minutes that is allotted. So our family advocates will have conversations with the family. They'll educate them about the organs and tissues that can be donated, the process in which DCD takes place. They'll talk to them about if they want to be in the OR when their loved one passes. Some of the things that our family advocates can also do is create a playlist that can be played in the OR for their loved one, and will also allow them to be able to say their goodbyes. It all depends on the hospital policy, as if we're able to have family present in the OR. Many times, most hospitals, pre-COVID and post-COVID, will allow 3 to 4 family members at most. We're unable to have 10, 15 people in the OR, but the close, really close wife, husband, mom, dad, we try to advocate for them to be able to be with their loved one when they pass. It is also okay if the family doesn't want to be in the OR. Our family advocate could be their representative in the OR. They'll hold the patient's hand, be with them, take care of them, and also, after the patient has passed, go out and let the family know that their loved one has passed away. They will be in the OR with the declaring physician, which many times they've known from the hospital stay, the bedside nurse, and also the RT to help with the extubation of the patient. IDN will have a couple of organ coordinators that are in the OR with them. However, we do not take part in the extubation or the declaration of the patient. We will have a separation from the recovery teams and the declaring teams. So DCD organ donor management is much different than the brain dead donor management. We go through and we work with the hospital staff to ensure that we are able to get the different labs that we need, all the testing that we need to determine whether this patient's organs are viable for transplant. We also make sure that the hospital knows that they retain full care of the patient until the patient is pronounced dead. We will ask for certain tests, like I said, a bronchoscopy sometimes, an echo if we feel that their heart will be able to be transplanted. We may ask for CT of the chest, abdomen, pelvis, just to give us a better look at the patient's organs. We want to make sure that we're doing the right thing, and we don't want to put a patient through a DCD process unless we feel that there will be even one life saved. The organ recovery coordinator will collaborate with the RN, the RT, and the physician to maintain the option for donation and organ function. We will ask for lab draws to determine how the organs are functioning, and it might also be needed for testing and evaluation of other things like HIV, hepatitis C. We do all our same testing for DCD and brain dead donors. So we will work closely with the hospital staff to ensure that we're able to draw all these labs and tests. This is a mocked ICU huddle with a physician, a bedside RN, and an RT.
Hello, I'm Jeff with Indiana Donor Network. As you guys know, we're going to move forward with the PCD of donation after circulatory death patient that the family has authorized this to happen. You're a physician, correct?
Yes.
And you're a nurse, and you're our RT?
Yes.
Perfect. I just wanted to huddle you guys together to give you some ideas what we need for our process moving forward so this miracle of donation can take place. Has there been a withdrawal here put in?
There has been one, yes.
Okay, thank you so much. There are a few other things that we'll need from you, if you don't mind, to help with our process, making sure that we can evaluate the organs, make sure that we're doing the right thing. We're going to draw some blood for our serology testing. It includes the HIV, hepatitis, along with many other tests, and the patient's ADO. We want to make sure that we're transplanting the right organs into the right patients. Our nurses, our coordinators will draw that. And with our bedside nurse, we'll work together to make that happen. Some of the other things that we might need moving forward in some testing, we'll probably need a bronchoscopy.
No, we just did one yesterday. You want to repeat one?
We still will, and we need to get a sample for COVID testing, so we'll need that, and we want to make sure that we can clear the patient out, take a look at the lungs, make sure nothing has changed over those 24 hours as we're moving towards the operating room for recovery of the organs, and we can match them up. We appreciate that. Some of the other tests that we need are CT, chest, abdomen, pelvis CT, so we can get a better look at the organs. If this is a trauma, we want to make sure that there's no trauma to the organs that we're going to transplant, or if there is, we can at least document it. We also might need an echocardiogram to take a look at the heart function, see how we're Now with DCDs, we're able to transplant all 7 organs, which is amazing. In the past, we haven't been able to do this with donation after circulatory death. So that's why I wanted the RT here as well, and the nurse to understand kind of what we're going to go through over our next 24 hours. With our vent settings, we may ask for a couple different changes in vent settings to be able to get some ABGs that our transplant centers are looking for. Do you have any questions on any of that?
Yeah, who's accruing the cost for all this? Is this family for all these additional tests?
The family does not include the cost on this. This is brought right back to Indiana Donor Network through the transplant and donation process.
Okay. So when I'm putting these orders in for these things that you guys want done, what indication am I supposed to have on the computer?
You can put in the comment section that requested by Indiana Donor Network. That will help the administrative staff be able to delineate what costs should go towards the organ donation process and what costs are normal. With our patient, we may need an additional art line if this one goes bad, or a central line to be able to use different medications to help maintain the option for donation. We're looking at possibly an OR within the next 24 hours. We're going to work with the family, work with matching up the gifts as best as possible to allow this miracle of donation to take place. With the nursing staff, what we might need, and we'll work with our coordinators, is hourly vital signs, hourly eyes and nose. We need to make sure what medications are going in the patient and how the patient is putting out those fluids. With our team, we're going to need some breathing treatments and maybe some CPT. We have a couple different modalities that we might use, and we may ask for some different vent settings if that's okay with you.
Yeah, we'll support you guys in whatever way we possibly can.
Okay, is there any questions that I can answer for you at this time?
When families, or when you're actually about to do a procedure, do we have to have another consent for that, for a broker?
So our family advocate actually went through and consented with the family and let them know that any of the testing that we require is in that consent as well. Thank you very much for being here, and we appreciate the opportunity to partner with you and make a donation.
We really like the buy-in and also the working together with the hospital staff to be able to make donation happen. We could not do this just on our own. It's very important to be able to have great conversation and have the teams work together. These are the organs that now can be donated during DCD. They can save as many as 8 people's lives. The heart, they can split the lungs into 2 patients. They can split the liver into 2 patients. Each kidney can go into a different patient, the pancreas and the intestine as well. General assessment, we do a chart review. We look at, also we have our family advocate do what's called a uniform donor risk assessment interview, or the DRE. It basically goes over the medical and social history of our patient. We do a deep dive into medical record review of the patient to make sure that we have all the information that we possibly need. When we draw our blood, we do a hemodilution or plasma dilution to make sure that we're getting a good sample to run all our serology testing and ABOs. Again, blood type, subtype, HLAs, infectious disease testing, blood, urine, and respiratory cultures will all be drawn. When we do our abdominal organ evaluation, we run our labs about every 8 hours. We'll work on making sure that we still have good kidney labs. We have transplanted in the past acute kidney injury that has creatinine up to 9, making urine, so we're able to place those organs on the pump. But during our evaluation process, we look at the CT, abdomen and pelvis, even a chest CT, but only order those if they're asked by the recovery coordinators that are on site. A little bit of a pulmonary evaluation. We're going to do ABGs. We're going to do an O2 challenge. Nationally, it's we have to do a O2 challenge on a PEPA 5 and 100% FiO2 for 30 minutes. This is standard across the board to give the transplant centers an understanding of where the patient is at with their organ function. We'll do a sputum gram stain and culture, chest x-rays, bronchoscopies, chest CT if needed. Cardiac evaluation, we'll draw some cardiac markers. We'll do a 12-lead EKG, echocardiogram, and possibly even a cardiac cath, depending on the patient's medical and social history as well. And we can transplant hearts up to age 55, sometimes even older if they're a good candidate for transplantation. We do have some orders that we have the hospital sign for DCD orders. It basically outlines what we'll need in our standing orders with different lab draws, and we can also add orders in there if we need to. When is the surgery? We always get asked, when is the surgery? Basically, when we are able to place and match up the gifts with all organs that we're going to be able to transplant. Then we will coordinate with the teams that are coming in, with the recovery staff, with the on-site OR. We could be also coordinating up to 6 ORs at other hospitals. And then we work to secure a physician that's going to declare the patient in the OR. Once all that has been done, we contact the OR, make sure that they have time available as well. We work side by side with them. Some of our transplant centers or trauma hospitals, it is very difficult to get OR time. Sometimes we have to work backwards and set an OR time in 24 hours and get as much done as possible due to the OR timing at hospitals. We try to work as closely as possible with our hospital partners. Prior to the OR, the ICU RN begins the death paperwork. It's very important because most of the OR staff does not know how to do the death paperwork. The ICU RN will gather all the comfort meds needed. All paperwork per hospital policy should be brought with the patient to the OR. We always recommend bringing enough comfort meds for up to 2.5 hours. The reason why we say this is because we could be in the OR for 30, 45 minutes prior to the extubation even taking place. The patient could last all 90 minutes and not expire. And we want to make sure that this patient is comfortable. Indiana Donor Network will not get involved in letting the hospital know what they should give for comfort meds. We do recommend the patient going to the OR on pumps for their comfort meds due to the fact that they don't have access to most PICSA systems in the OR. ICU nurses will not have all the access that OR nurses will have. We want to make sure that the patient passes in comfort and dignity, and that's always the main goal in this. Donor process in the OR. So the DCD OR process and education. The more we talk with people, the better off it's going to be. We work together with the entire team. We want to make sure we over-communicate. A team huddle will be held to explain the OR process and to answer any questions. The huddle will consist of the family advocate, the organ recovery coordinator that's been there for the last 24 hours, the surgical recovery specialist that's really specialized in the OR procedures, professional services coordinator, the ICU staff, respiratory therapists, the OR staff, and the declaring personnel, whether it's the physician, multiple nurses, per hospital policy. This huddle is imperative to ensure that everyone knows the roles that they will perform in the OR. This will also include a detailed exit strategy with the family advocate and the family once the patient is passed, if they are in the OR. The surgical recovery specialist will review the process for the room setup with the OR staff, how the declaration of death should take place, and also talk about the recovery with the OR staff involved. This includes reviewing any equipment needs, utilizing the organ recovery surgical list form that we will provide. The ORC will also provide the names of the qualified hospital personnel who will be declaring death, and we will also have the names of all transplant center faculty that will be in the OR. The ORC will ensure that any medications that's needed for the recovery process, whether it's TPA, mannitol, heparin, whatever the transplant centers need, will also be in the OR, so it's readily available for the time of recovery. We'll talk with the bedside RN and physician to make sure that any and all comfort medications that the hospital has chosen will be available for the withdrawal process and prior to the patient arriving to the OR suite. The surgical recovery staff will remind the OR staff to cover all windows in the OR and ensure that there's privacy for this patient and this family. The ORC will assist the RN and RT in transporting the patient to the OR. The ORC and SRS will assist with positioning, prepping, and draping of the patient in the OR, and also the organ recovery staff to make sure that all equipment as needed will be present and ready for the recovery. Prior to the donor hospital withdrawing life-sustaining support, the ORC will conduct a timeout to confirm the patient's identification, the process that we're going to do in the life-sustaining treatment or ventilator support withdrawal. We'll also talk about the roles and responsibility of the primary patient care team and the OPO team and the recovery staff team. The ORC will ensure that the recovery staff that are there from the transplant centers and the hospital staff are separated during the time of extubation. We do this so that there's no influence or even the misguided thoughts of influence on determining this patient's death. Here's an example of an OR huddle with the circulator and the scrub with the surgical recovery specialist.
Jeff, this is Shelby. We're with Indiana Donor Network. Thank you guys for being here today to take part of this donation after circulatory death organ donation. This is really a family-driven process, so we really appreciate any help that you guys can give us. We wanted to huddle with you just for a few minutes to kind of explain the procedure before we bring the patient down. And what are your roles here today?
I'm the scrub.
Okay, secretary. Again, have either of you done a donation of circulatory death? Okay. I still like to go through our process just in case we've changed anything. We may be able to answer any questions for you guys that may come during this or questions that you've had in previous experiences. So how this happens is we bring the patient down on the ventilator with the ICU team, the nurse, the RT, and the pronouncing physician. We'll get the patient in the room. We will prep and drape, and we'll already have the room set up. So a couple of things that we really need set up fairly quickly are the slush machines. And we'll also go over with you what we need on your back table to make this process go a little faster. As you know, with DCD processes, we've done these before, is the initial first few minutes after the patient has been pronounced go really quick. So we want to ensure that anything that you could possibly need is close at hand. We will also, during this time, we will set everything up that we need to help perfuse the organs. Do you have any questions on any of that so far? Okay. One of the things I wanted to kind of talk about the process in the surgical process itself. So after the patient's been pronounced, we will be hands off for 5 minutes. During that time, our physicians, the recovery staff, will be able to scrub and be ready at that 5-minute mark to make sure that the patient's heart rate is set back up. Once we get clarification from the pronouncing physician that this does not happen, we can make an incision. What we'll do is quickly go in, we'll find the distal aorta, we'll cannulate that, and we'll open the chest to be able to help with the procedure. It is very important that we're able to cannulate quickly within a minute to a minute and a half, and we get the fluids running, and then we'll cool down the organ as quickly as possible. Any questions on that? All right. We'll go over in just a second what you'll need on your Mayo stand and on your back table. And if you have any questions during this procedure, just let us know. Awesome. Thank you.
Again, that's a simulated huddle with the circulator and the scrub tech in the OR. This is kind of a setup of the supplies that are going to be needed in the OR. It's very simple, just a different way that we bring everything together, and we work with our hospital partners to make sure that they have everything that they need. Here's an example of a thoracic Mayo stand setup that we will need some different tools to have: a chest retractor, a sternal saw, some DeBakey, some Mets, and a clamp. OR staffing needs. We will need at least one circulator, one scrub, and if we are going to transplant the lungs during the DCD process, we'll need the anesthesia staff to be able to help with reintubation and also hook them up to their machine, because we will ventilate the lungs at that point. The physician providing end-of-life care will be arranged by the ICU team, of course. Here's an example of kind of the organ recovery process.
At this point, the patient has been pronounced, and we have the surgeons that are scrubbed in. We'll have our scrub tech ready to go. These are some important instruments that will be on the table, and here's the reason why. We will do a very fast incision from the sternal notch all the way down to the pubis. we will open up the chest. So if you look at our thoracic table that we have set up, we'll have a sternal retractor, we'll have a sternal saw, we'll have an 11 blade on there, and we'll have some additional DeBakey's and Mets and a clamp. If we look at our abdominal section here, we have our perfusion tubing that's here with a cannula, and I'll have Shelby talk to you about that in just a second and what we'll need to do to perfuse that or get that ready. We'll have a large right angle, we'll have some heavy ties on a passer, and we'll have 4 perforating towel clips. We'll take and make our incision, we'll open up the sternum, and then we'll do a cruciate cut in the abdomen. We'll go down and find the distal aorta as quickly as possible, and we'll cannulate with our cannula to help start perfusing the organs. These are the most important pieces to have readily available as soon as we start the surgery. This will all take less than a minute and a half.
And here is Shelby talking a little bit more about getting the perfusion tubing set up and the needs that will happen then.
Yes, my name's Shelby. I'm going to be the preservationist for this case. So after the 5 minutes pass, we're going to rush in here, and it's going to be very quick. The surgeons are going to be asking you for the instruments that you already have set up, and I'm also going to be asking you to help me perfuse our perfusion tubing. So basically what that is that's this tubing right here. I'm going to spike a perfusion solution called circulatory H, and I'm going to use that to perfuse that line, and we're going to need to get all of the bubbles out, and that's going to be needed to be ready for the surgeon. After they make the incision, they're going to cannulate in the aorta for that. So basically what that is we're just trying to cool down the organs as soon as possible so that they can be prepared and packaged up for transplant. So what I'm going to need from you is I'm going to need for you to grab a basin of any sorts. It can be a cup or one of your basins on the back table, and just put the end of that tubing into that basin, and then just run that fluid through, and then let me know when you don't see any more bubbles on your end. Okay, and then the surgeon will ask for it, and he'll just have it clamped, and then I'll actually have control of the line, unless the surgeon would like to have control. If he does want control, he'll just need a tubing clamp to clamp that on your end.
Awesome.
Okay, thank you.
So family support prior to the OR. At times, as was mentioned earlier, the family will want to be with their loved one in the OR. The donor family may choose to be present or not present. It's totally up to the family and what hospital policy is. Indiana Donor Network's family advocate will help to facilitate the option for the family to be there. They'll talk about the DCD process that was stated earlier, assure the family understands, just to reiterate, what they expect to see. The OR team will notify the family of the decision if needed. A request for appropriate OR attire will occur. The families need to either be dressed in bunny suits or OR scrubs to go into the OR. So some consideration for the family is we like to drape the instruments. So after we set up the field, we'll push them to the side, and we'll get some IV poles. We'll place a couple of sheets up to protect the sterile field. And so then the family doesn't think it's quite like an OR setting. It is an OR. There's no question. They understand that. It's been explained to them kind of how it will be set up. We'll try to dim the lights and play any music to try to make it as comfortable as possible for the family and the patient themselves. So any special considerations that we have with the hospital staff, we try to maintain the comfort of the patient. That's primary. Comfort of the patient, the family if they're present. IDN staff will not be part of the withdrawal process. We will be in the room. We'll have organ recovery coordinators in the room to maintain and watch the sterile field to make sure it stays sterile. Hospital staff, their scrub tech may stay in the room to make sure that the sterile field stays sterile. But Indiana Donor Network does not have any influence whatsoever on the withdrawal process. We do recommend, again, to make sure that the patient's comfortable. The transplant surgeons will not be present in the room during withdrawal process. We have a separation of extubation that was explained a little bit earlier. The sterile fields just need to be maintained and monitored. The OR suites try to have all the windows covered, privacy for the family, of course. So this is just a picture of with family in the OR. Our hospital advocates there to help them through the grief process, to make sure everything goes smoothly, to show them the way out of the OR once their loved one has been declared deceased. Again, the family advocate has a in-depth conversation with anybody that's going to be in that OR prior to even going down there. They understand what they're going to see during the withdrawal process. They're going to understand that, if their loved one appears to be in pain, to talk with the hospital staff and let them know their feelings. We want to make sure that everybody dies in dignity. Here is a little bit of a setup in the OR with prior to bringing the family in.
So after we get all set up and we have the physicians have everything that they need set up on the back tables sterilely, what we do is we set up the room so it's most comfortable for the family if the family is allowed in the OR. We set up some sheets to protect our sterile field back there. We've added an extra sterile drape on top of the patient to keep the sterile field safe. And then we bring the head cover back over the patient. We have some tables or some chairs set up for the family to sit in. Typically, if this was not a simulation, we would have a patient with their arm out so they can hold the hand and also be able to talk to their loved one and see their face. The head of the bed area will have the IV poles for the medications that are running for the patient to make them comfortable. This is still an OR setting. However, we try to make it as comfortable as possible for the family. We'll try to play music for the family if it was so desired by the family or the patient had a playlist that they really enjoyed listening to. Our staff would be able to help you with this setup, and it allows the sterile field to be safe and the family to be able to see their loved one and hold their hand.
If the family has a special blanket or anything that they would want to try to make it less OR looking, we would be able to put it over that setup that we have right there and still maintain sterility. So a little bit of brain dead versus DCD in the OR. In the brain dead, you'll have the anesthesiologist present. You'll have the surgical team present. No family will be present in the OR. We'll give some heparin 3 minutes prior to cross clamp. In other words, we have already started the surgical procedure. We went down, we've looked at and evaluated each organ and their systems. We have no declaring physician that needs to be present because the patient has already been declared brain dead. In the DCD process, we won't have an anesthesiologist in the room unless we need the patient to be reintubated and we'll need some ventilation of the lungs and Valsalva processes. No surgical team will be present in the OR during the withdrawal process, and family may be present in the OR. Heparin will be given at the time of withdrawal, and then declaring physician will be present along with the ICU nurse and possibly even the RT. Why do we wait 90 minutes? Some programs will even wait 120 minutes. Some will even wait longer than that, depending on organ function, the patient's stability, and during the warm ischemic time that we talked about earlier today. This is just an informational article out of the American Journal of Transplantation from 2017, explaining to you the programs. There was several programs that waited for 60 minutes and others that waited for 90 minutes. And they determined that waiting 90 minutes, there was better chance for organ donation and transplantation. And when they waited the 90 minutes with the patient's warm ischemic time, many times they were becoming more kidneys available for transplantation. So across the board, most of the nation is trying to wait 90 minutes, if not 120 minutes. So these are the successful DCD donors that we've had in Indiana Donor Network over the last about 6 years. If you look in 2016, 2017, there were not as many DCDs pursued. For instance, in 2018, we started to climb, 2019, and then 2020, we really jumped a lot. And if you look at 2021, we have done 43 successful DCDs this year, and those numbers are as of July 1st. DCD review of organs transplanted. So as you can see, kidneys are always the highest number in a DCD process. They're the most resilient. However, we have transplanted 112 livers, 57 lungs, and 10 hearts, which just really started coming to be prevalent in the last about 8 months with DCDs, 5 pancreases. So as you can see, in a review of the previous 5.5 years, 488 organs were successfully transplanted using the DCD process. That is 488 lives saved, 488 fathers, mothers, brothers, sisters, and loved ones that were able to have new lease on life. That is 187 donors that became heroes to people they never even knew. That is 187 families that were able to have something positive happen from their loved one's death. This is just kind of an overview of how many minutes it's taken for our patients to pass in a DCD process. The average is 23.6. However, this data was taken from 2018. We're working currently on the 2021 data, but we find that it's pretty similar. We will extend a little bit longer. As you can see, the 72 minutes and 75 minutes in there. I just wanted to show this to you to get an idea that most of the patients that we're pursuing are dying in less than 40 minutes. These are some of the recent advances of DCD process. We're able to do HCV positive organ donors in DCD process. In the past, a couple years ago, it wasn't even heard of to be able to pursue HCV donors. DCD heart transplants, as you see, we had 10 transplants in the last 8 months of hearts, and we continue to grow with that. We just performed ex vivo lung perfusion. We've worked with a company called Lung Bioengineering to help have the ability to transplant more lungs. We're constantly trying to pursue ways that would allow DCD donors to take place. So in summary, DCD donor summary, basically the family elects to withdraw support. I just wanted to go over this one more time. The authorization and disclosure with the family. We talk with the family. We do our evaluation of the organ systems and work with the hospital. We partner with them to get all the information that we need, and then we are able to match up the gifts. We withdraw medical therapy in the OR. There's a pronouncement of death. We wait for 5 minutes, and then we make incision. If the patient does not pass in that 90 minutes, then we will move the patient back to a predetermined room. We always prepare for that. If the patient does not pass, what's going to happen? We work with the hospital staff to make sure that either they're going back to their same room they were at, or they will be transferred to another hospice room, step-down room, to allow them to pass in dignity with their family.